Today we are going to discuss a case of left common iliac vein thrombosis. This case is about a 40-year-old young man who presented to ED with abdominal pain. He has a background of intravenous drug abuse as well. So the routine bloods, they were normal, but because of the worsening abdominal pain, we went for um, CT abdo and pelvis directly instead of abdominal X-ray. The CT abdomen and pelvis shows that there is left common iliac vein thrombosis with findings suggestive of bilateral renal infarcts. This was a little bit confusing because the patient has both um, vein thrombosis and renal infarct, which is the arterial infarcts present at the same time in this patient. Because of the history of intravenous drug abuse, we decided to check the um, cardiac status of the patient. We thought maybe there is some endocarditis and the vegetations may have dislodged from the valves to the renal arteries. So we did an echo scan for this patient and it shows no vegetations, but there was a finding of patent foramen and ovale, PFO. So our conclusion was that the thrombus from the left iliac vein has mobilized and passed through the PFO and has gone to the renal arteries, causing renal infarct. So we initially started him on low molecular weight heparin treatment dose. His platelet counts were normal. He has no previous bleeding history. His renal functions were normal as well. So we gave him the routine adult treatment dose of heparin, which is 1.5 milligram per kg of enoxaparin. We use enoxaparin in our trust. After stabilizing the patient for 7 days, we decided to convert to DUAC. So we started him on apixaban, 5 milligram BD dose for this patient. Apixaban needs loading dose first, like 10 milligram for 7 days, and then 5 milligram afterwards as a BD dose. Then the team contacted us that for how long this patient should continue um, anticoagulation, whether it should be 3 months or 6 months or lifelong, because we think that the intravenous drug abusing is the provoking factor in this patient for left iliac vein thrombosis. So the background of the patient also contained ulcerative colitis. So due to presence of ulcerative colitis and intravenous drug abuse history, we decided to continue apixaban till infection is completely over and till cardiology decide to close this patent foramen ovale. Once the PFO is closed, then we can stop the anticoagulation for the patient. Otherwise, this patient would be at risk of developing another clots and passing of the clot through PFO, and it may cause stroke or MI next time. So currently, this patient is on apixaban and antibiotic therapy as well. We have checked the interactions to make sure there is no interaction between DUAX and his antibiotic therapy. Once this patient become fit and infection free, then cardiology people would operate his PFO, and after that, we would stop his anticoagulation. So this was a good case of vein thrombosis leading to PFO, leading to renal infarct due to presence of PFO.